Hi, my name is Clare Flannery. I'm an endocrinologist and a researcher in women's health, diabetes, and body weight here at the Yale School of Medicine. And today I'm very excited to have a conversation with Dr. Sonia Caprio, who is also an endocrinologist here at Yale and who studies how body weight and diabetes evolves in children and teenagers. I've long admired her work, and so this is a privilege to get to speak with her. We have recently joined forces, so to understand how these children and teenagers have now grown up as adults and how they're doing.
Thank you very much for inviting me, and yes, the interest is there for particularly it started as the focus was in diabetes, and slowly we understood that there was a link between type 2 diabetes and obesity. My interest was mainly in children to see if I could bring whatever the experience that we have and had in the field of diabetes to, at that time, I must say this was the beginning of 1990s, things like that, and there was very little diabetes, if ever, type 2 diabetes in youth. So little by little, we focus more on the metabolic syndrome to see if kids with obesity were also having other problems in the lipid system, for example, lipid assessment and hypertension. And at that time, there was no fatty liver yet as a problem, at least in kids. So little by little, we moved and understood that many of the problems that we have in overweight and obesity in adults were also seen in the adolescents that I was seeing in the clinic.
Yeah, so your career in service of children and teenagers has now spanned over 30 years with funding from the National Institutes of Health, which is quite prestigious. And I know that you've written over 150 peer-reviewed publications. You know, many of the children and teenagers who saw you in clinic participated in these studies.
Yeah, in fact, it started very fast because we started doing these very simple tests that were reasonably accepted by a young person, a child, basically, because it was from the age of 7 and up. Once we started the idea that we should basically focus whether there was pre-diabetes in youth with obesity, we started by doing these tests that were fairly well accepted. Every child will drink that sugary test, basically, but that was the main point, to do a test, a simple test, not very invasive, that would allow us to know where the glucose tolerance is, basically, if it's altered or not, and to repeat that in 2 years as a follow-up. That's what we started doing. In the meantime, because Yale was very and is still very famous for doing imaging of the body, so we were the first one to do really the imaging of adipose tissue in children that were overweight or not. And so we combined the two things, and we started doing these tests. And I would say that by the beginning of 2000, we had about 200 kids that underwent the OGTT and the imaging. And that paper was very important, at least was accepted in the New England Journal of Medicine. And that opened the door to see, to let people understand, that the start of diabetes started very early, type 2 diabetes, very early in these kids. So that's what was the first step, and was very well important because then the NIH decided to do trials in kids with obesity and type 2 diabetes and see what would be the best way to treat this problem in kids.
And why is it important to diagnose children and teenagers?
It's very important because the earlier you started the problem, I mean, you know that they have it, because it's not like type 1 diabetes that it comes out and you cannot miss it. Type 2 diabetes is sometimes pretty silent. So you see that in the silence it was there, we did not know about it, and by doing the OGTT and the imaging, we realized that there were other issues in these kids. So we started basically with type 2 diabetes when NIH also was willing to propose a study to see what would be the best way to treat type 2 diabetes in kids with obesity. And that was 2002, 2003 that we had the first big center, a group of, there were 13 centers that the NIH selected and to do this study that they wanted to do, basically. And this was the first time large a study to understand what is the problem of type 2 diabetes in such a young population.
Now, 30 years after you started, there's over 2,500 individuals who took part in these studies. They are now in their 20s, 30s, and 40s. And I'm curious what you would want them to know now. And we both know that we care how they're doing now, which is one of the reasons I've got involved as an adult endocrinologist. But are there things that you would want them to know?
Yeah, the continuity of this problem is very important because unfortunately up to 21, the pediatrician gets out from so I cannot connect with them anymore. So having a person in the field, endocrinologist, and knows the metabolism, I think is important. And if we can, our goal is to reach out to these people, particularly in some aspects of the problem, to see if we can see where are they having problems, and even some of them have developed type 2 diabetes and other issues now because they have their own family, they have the obesity does not go away, and the type 2 diabetes as well. So it would be very important to have, based on what we saw when they were adolescent, what's happening now also, and how best we can treat them. I would love to know where they're doing, some of them I know because they have other younger brothers and sisters that are still in my clinic. But those that have matured, they have kids, they're on their own. And that's important because also you don't want to, have these type 2 diabetes and go into pregnancy and things like that. It's another very important area that I don't see a lot of work there. So there is a great deal of research. We are, I think, in a moment in research and in science now to understand that overweight and obesity is there and is not going to go away. The key issue is why. It's always the weight that has to go down in order to see that, your glucose tolerance is better, the liver is doing better. And so that would be a major step. And our goal is really to stop the diabetes, type 2 diabetes in youth, because it's a silent disease. And if you don't take good care, they're gonna have most likely some issues later on,
And I believe also from your work, a side message that comes through is that not all children are equally at risk, and we never want to overtreat those who never needed it.
Yeah, it was clearly to us that the disease of diabetes would start after they had the early puberty, adult puberty. So the mean age was 13. You seldom was seeing, very early diabetes in prepubertal kids. It's very rare, but it was there when they were in adolescence. Prediabetes is very easy for kids, particularly, I would say, boys going back to normal. So we have a paper in the Lancet showing that after 2 years, what was happening to the cohort. Do they still have the prediabetes or not? But a good 60% went back, but they were all, I have to say, white going back to the normal state, as opposed to the African American that had full-blown type 2 diabetes. Yes. And girls.
The girls were the most.
The most at risk for the diabetes, yeah.
And your work looked into the genetics, right?
When you see in clinic, that's in our clinic, basically, a child with an elevated ALT and PDFF, an assessment of the fat in the liver, and you confirm it. And then the problem is how common is that at that age, and why are the father and mother also having the same issues? And again, it's strongly dependent on the ethnic background of the kid.
Yes, because of the genetic contributions that would have come in. Your work was also done in collaboration with others like Mary Savoy, and doing the very important work with Bright Bodies, offering exercise programs and ways of thinking about physical activity and food. I wonder where you think that plays a role in the overall lifespan.
I think it would be very important to keep on going this program, because if you catch and educate the family and the kids very early to understand that the future can be tough, not necessarily, but if you do it early, I think the chance that really the child would listen to Mary or the other people that are doing this program, they might stay with the child and the family and not get to a desperate condition. It's like a sponge, the child, when they're very young, they absorb what is good for them and not. And that's what we have to prepare to this new generation.
There's an important window of time where we can be.
Yeah, I think that window is very important, because these kids, most of them are growing up. You know why? And increasing their weight, the snacking. Snacking is the big problem that they're facing.
Yes, but we have a lot of environment encouragements for snacking.
We have to protect them and let them understand that there are good snacks, fairly few of them, but you cannot live on snacking. Snacking is becoming the meal for the kids now.
The way our bodies see food very early in life will program how we continue to see it later on.
We have to be honest, because we are reaching really a sad moment, I would say.
Yes, for our food environment.
Yes, because they are very attracting. They're full of salt. They know they're smarter than we are, these people making these foods, attracting their taste and things like that. But these are young kids.
So having taken care of so many of these children and adolescents through their growing years, what is your worst fears about what adulthood has for them?
Well, I have to say that the experience that we had, and we saw what was happening in the kids that have been enrolled in the Today study, basically. And you saw that the major complications were already at the age of 25 there. That means the kidney, some of them have severe depression, and the other one was fatty liver. Okay. So these are three conditions that are appearing at a relatively very young age, in the 30s, 25, 30 years. And again, this was thanks to the help from the NIDDK really embarked in, I would say, 12 years of work we did in that area to find out that these kids are marching towards early complications. So we don't want that to happen. We have to stop that, because I think there is enough knowledge for us to understand and diagnose early the issues and stop it.
Yes, I also think of where the direction needs to head, what we need to know, and what next needs to be done. And you've been hard at work thinking about the medications, both for the children and for the adults as they grow up. And one of the studies you're doing is on semaglutide, which will have great impact. What things do you believe still need to be done in the field?
There is a lot that we need to understand, because even with this wonderful new medication that are coming out, which it's the first time that we are seeing some very good improvement on the weight of a person, that we never seen that. I mean, very rarely. And not only it's just the weight that we are addressing, for example, and this is valid both in kids and in adults. Of course, the adults are ahead of us, because it takes time really to convince that there is a younger population that needs also some help. So we started to use, for example, in this trial that we're doing now, is with semaglutide, like I said, Ozempic or Wegovy. We chose Wegovy because the focus is on obesity. But it's a mechanistic study that we're doing, because we want to see whether the medication is also affecting fat in the liver and the prediabetes. The study that we are doing, hopefully, will show whether the fat in the liver and the prediabetes are sensitive to this the semaglutide, and that would be a major step, I would say, in the field. We need better medication, and just like the blood pressure or other issues that we take forever, these medication, we have to convince that this is totally normal to treat overweight and obesity with an injectable or non. Another big issue is the cost of the medication. So that we forget about it, but many of us will never be able to afford it. So there has to be something done, because it's to see obesity or overweight as a disease is serious, and the drug that they are making, the new drugs, are all injectable and too expensive for us, for any one of us. So I don't know the future. This is happening particularly in US. In Europe, I know it's totally different. The cost is much less than what we are, say, fighting for now here in the US.
Yes, and I appreciate very much your encouragement.
I love talking to you and to continue the research that we did, because many of these women basically need your help a lot to avoid much more complicated situation that they're living in.
Thank you, Dr. Caprio, for this time with you.
Thank you all.